The subcommittee will come to order. The chair will recognize himself for an opening statement. Today's hearing focuses on H.R. 5411, the Trafficking Awareness Training for Healthcare Act of 2014. The bill would support the development of evidence-based best practices for healthcare providers to identify and assist victims of human trafficking. Healthcare providers are among the few professionals who have the opportunity to interact with trafficked women and girls. Because of unusual House scheduling conflicts today, we had to delay the start of today's hearing, and therefore we will dispense with members' oral opening statements. However, members' full written statements will be included in the record. On our first panel today, we have Ms. Catherine Chan, a Senior Policy Advisor at the Administration for Children and Families at the Department of Health and Human Services. And I understand that Ms. Chan must leave by 10:30 today for the airport. So to maximize members' opportunities for questions of Ms. Chan, I will ask her to please summarize her statements in a few minutes. And with that, Ms. Chan, you're recognized and may begin.
Chairman Pitts, Ranking Member Pallone, and members of the subcommittee, thank you for inviting me to testify to share with you the Department of Health and Human Services work to prevent and end human trafficking in all of its forms. HHS recognizes that human trafficking is not only a violent crime, but it is also a global health problem. The goals of the Trafficking Awareness Training for Healthcare Act of 2014 would complement HHS's anti-trafficking efforts to build the capacity of first responders to identify and serve victims of human trafficking. In our ongoing engagement with healthcare providers, this week, HHS started a series of our pilot SOAR to Health and Wellness trainings for healthcare professionals, in which SOAR stands for Stop, Observe, Ask, and Respond to Human Trafficking. This training seeks to increase knowledge on the diversity of human trafficking, identify indicators, utilize trauma-informed care, and connect with local and national service referral resources for trafficking victims. We are partnering with local hospitals and community clinics in Atlanta, Boston, Houston, Oakland, and Williston and Newtown, North Dakota for the trainings, which will be evaluated later this fall. While the SOAR trainings currently targets healthcare providers through hospitals and community clinics, the bill broadens the reach of training efforts to health profession schools. In addition to accredited schools of medicine and nursing, we recommend dental and social work schools as important target audiences because research has shown that victims of trafficking have encountered dentists, and hospital and clinic-based social workers are often responsible for managing the follow-up services once a victim has been identified. The bill also references evidence-based practices. Since there is little evidence-based research specifically on the intersection of the healthcare system and human trafficking, the anti-trafficking field may be able to adapt lessons learned from efforts in related issue areas, including the treatment of domestic violence and sexual assault victims in healthcare settings. Additional opportunities for healthcare engagement include building the capacity of public health professionals to help prevent human trafficking, including interventions like the John Schools, which provide information to purchasers of commercial sex who have been arrested and then participate in educational programs on the health and behavioral health consequences of their actions. The administration looks forward to working with each of you to build the capacity of healthcare professionals to address the needs of victims of human trafficking. Again, thank you for the opportunity to testify today, and I'd be happy to answer any questions.
Thank you. We'll begin the questioning. I'll recognize myself 5 minutes for that purpose. Ms. Chan, according to the Compendium of State Statutes and Policies on Domestic Violence in Healthcare, which was funded by HHS, it states that, quote, the goals potentially served by mandatory reporting include enhancing patient safety, improving healthcare providers' response to domestic violence, holding batters accountable, and improving domestic violence data collection and documentation. However, upon closer examination, it becomes apparent that mandatory reporting does not necessarily accomplish these goals, end quote. This statement seems to discourage mandatory reporting by healthcare workers Is that the position of HHS? Is there research to support this position?
So I am less familiar with the mandatory reporting guidelines around domestic violence, but one thing that we have heard from healthcare providers specific to human trafficking is that there have been concerns or questions from healthcare providers on reporting requirements balanced with HIPAA regulations when it comes to identifying victims of human trafficking. And so what we're encouraging in our SORTA health and wellness training is being familiar with HIPAA requirements, but also familiar with the local and state statutes around mandatory reporting and the healthcare institutions' protocols around reporting. And universally, though, we do encourage identifying referrals for follow-up social services within the context of institution and state local guidelines, as well as federal.
Well, you know, that statement seems to discourage mandatory reporting by healthcare workers. Does that or should that position apply to human trafficking?
Well, in terms of mandatory reporting for human trafficking, part of it depends on the type of human trafficking that a healthcare provider may come across. So for victims of child sex trafficking, for example, in many states, they're also victims of child abuse according to the state laws, and there are very strict mandatory reporting guidelines there. In our SORTA health and wellness training, we do go over the specific situations in which mandatory reporting would be required by law.
Can you explain what the Stop, Observe, Ask, Respond to Human Trafficking, the SOAR training program entails, how the training was developed, and how the cities participating in the pilot were chosen?
Sure. This training is part of one of our many commitments in the Federal Strategic Action Plan on Services to Victims of Human Trafficking. It's an interagency plan which HHS co-chaired with the Departments of Justice and Homeland Security. And during the public comment process, the anti-trafficking field called for increased training for healthcare providers. So we identified and formed a national technical working group of subject matter experts, including many healthcare professionals across a wide spectrum of specialties that have experience in training healthcare providers. We also had service providers and survivors of human trafficking inform the training. It went through federal interagency review and was based on a literature review as well. The sites were selected because this is a pilot. We selected 5 sites in areas where we could develop strong partnerships with local stakeholders and healthcare providers who were already experienced in responding to this issue. So Boston, Oakland, Atlanta, and Houston were chosen for those reasons. And then Newtown and Williston, North Dakota was chosen because there were concerns around the increase in various forms of violent crimes, including human trafficking, and the need for the healthcare system to receive training to identify and respond to a relatively new issue that they felt they were seeing in that area.
Can you explain how HHS was involved in the development of the Federal Strategic Action Plan on Services for Human Trafficking in the United States, and what goals has HHS set in the Strategic Action Plan?
Mm-hmm. So the goals are, the Strategic Action Plan has 4 primary goals set not just by HHS, but through a collection of more than a dozen federal agencies and partners. It is available online. We'd be happy to also provide a copy of it as well. And as I mentioned, we co-chaired this process with the Departments of Justice and Homeland Security. The draft plan was based on a number of community listening sessions across the country, national calls as listening sessions as well, literature review, and the draft was released for public comment last spring, and then federal agencies reviewed the public comments throughout the summer and fall, finalized it, and then the final version was released this January.
Chair thanks the gentlelady. Now yields to the ranking member, Ms. Pallone, 5 minutes for questions.
Thank you, Mr. Chairman. Last week, I had the opportunity to visit the U.S.-Mexican border, and the Administration for Children and Families plays an important role there, providing critical health and welfare services to the unaccompanied children who cross that border every day. We all know that the unprecedented number of unaccompanied minors have arrived in the U.S. and needed ACF services this year, and Congress clearly has a responsibility to ensure that this agency has the resources that it needs to do this work. We don't want the Administration for Children and Families to be forced to relocate funds, to reallocate funds from other important programs, such as the ones we've heard about this morning. So can you just discuss the importance of providing adequate funding for the Administration for Children and Families programs to address the needs of both domestic and foreign victims of human trafficking? And in its fiscal year 2015 budget, ACF proposed an increase of $8.2 million to specifically assist domestic victims of human trafficking. Can you comment on the type of work the ACF plans to do with that money?
Sure. Well, the good news is we have not had to reallocate any of our anti-trafficking funds to address some of the unaccompanied minor needs that have risen over the past year. And in terms of the budget request, the increase in funding will allow HHS to serve all victims of all forms of trafficking, so foreign nationals as well as U.S. citizens and lawful permanent residents. Pretty much over the last decade or so, the budget on addressing human trafficking has been fixed around $10 million, primarily going to serve foreign national victims of trafficking. In this current fiscal year, we received an increase in appropriations, which gave us enough to provide demonstration grants to start serving domestic victims of trafficking, so U.S. citizens and lawful permanent residents. And so what we intend to do if there is a further increase in the budget is to bring parity, at least in the budget that goes to serve domestic victims, to match up the budget that has been going to serve foreign national victims.
Thanks. I also wanted to hear more about the SOAR for Health and Wellness initiative and the pilot trainings that are beginning this week. So let me ask what kind of interest you've seen from the communities that are conducting pilot training over the next few weeks, and after participants complete the pilot trainings, what kind of evaluations do you have planned, and what do you plan to use these evaluations to think about the future of the SOAR program?
Sure. So there has been significant interest in the specific pilot locations, registrations. We've been meeting our goals for this pilot program. We were targeting about 45 participants per site, and in some sites, like in North Dakota and Houston, there are multiple trainings that are being held. And it's not just the pilot sites, but we're hearing from other communities. Healthcare providers are asking for additional resources on training and technical assistance, which HHS partly provides through our National Human Trafficking Resource Center. Healthcare providers can access that at any point. And then in terms of the evaluation, there's a pre and post test for this training and a 3-month evaluation survey, and a subset of the participants will participate in qualitative surveys as well, and we will release the findings of the evaluation next spring.
All right. Earlier this year, the Departments of Justice, Homeland Security, and Health and Human Services released the Federal Strategic Action Plan on Services to Victims of Human Trafficking in the U.S., and it outlines a number of specific actions that different federal agencies are going to take. I understand you were involved in the development of this plan. What types of comments did you receive from healthcare professionals during this process regarding the need to improve the healthcare system's response to victims of human trafficking?
The overwhelming response that we received through the public comment process from healthcare providers was a need for additional training and resources especially if it could be in some standardized way, and also tailored to the specific healthcare professions. We also heard comments on having screening tools, especially if they could be validated and be evidence-based. And the type of training that we're providing is different from a longer-term curriculum that could be available through educational institutions, but we also heard the importance of developing skills through curriculum-based efforts in educational institutions.
All right, thanks a lot. I just wanted to say with regard to the SWORD training, I'm glad that HHS is evaluating steps in place to assess the effectiveness of the pilot program, and I think this work would help provide helpful feedback as we think about what role Congress and the federal government can play in assisting the healthcare community to respond to the needs of trafficking victims. So thanks again, and thank you, Mr. Chairman.
Chair thanks the gentleman, and now recognize the gentlelady from North Carolina, Mrs. Elmers, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you, Ms. Chon, for being with us today. And I know you have limited time, so I'll try to get through my time so that we can allow anyone else for questions. I really want to focus, and first of all, I want to say thank you for what you're doing. And the SOAR program sounds like we are moving forward on a really good HHS initiative. We feel very strongly that we want to expand that, and we want to make sure that we are reaching out and including our education for medical students, nurses, and that really has to do with what we're trying to achieve here with the bill that we have. And of course, as you know, funding is an issue. We want to make sure that there's adequate funding for this project. And I was wondering if you could comment from that perspective on some funds that are available through HHS, the Prevention and Public Health Fund, or the PPHF, which basically helps to fund innovative projects and outreach. I believe that this is one of those areas that, especially when we're moving forward with healthcare, that this could be a positive funding source through HHS that's already there, and call on Congress to appropriate funds to it. Would you like to comment on that?
Sure. In terms of my knowledge of those particular funds, I don't believe they've been used for anti-trafficking training purposes in the past, but I'd certainly I will ask the appropriate divisions within HHS of how those funds could be used for these purposes, and then would be happy to get back to you on those possibilities.
Great. That would be great if you could get back to the committee on the response to that, because I think there again, as we're moving forward, we would like for this to move as quickly as possible, and we too have suggested a pilot program with feedback so that we know what is working and what isn't. And I think the training and the education piece of it, component of it, for our medical students and our nurses, so that they are being exposed to this information. One of the things that I found over time that is so vital is that many people do not realize this is happening here in the United States, and that this is something that we have to make sure that our healthcare providers are understanding and aware of. And again, I'll yield back. I just again want to thank you for being here today, and thank you for sharing your information, and I'm looking forward to working together on this. Thank you. And I yield back.
Chair thanks the gentlelady. I recognize the gentleman from Georgia, Mr. Barrow, 5 minutes for questions. Chair recognizes the Vice Chairman Subcommittee, Dr. Burgess, 5 minutes for questions.
Thank you, Mr. Chairman. I apologize for being late. There's a lot going on this morning. Ms. John, thank you for being here. Your agency is one that has perhaps come to the attention of this subcommittee a great deal more over the last 6 months for a variety of reasons. But as we're here today to discuss the prevention of human trafficking, I seem to detect that there is a system of best practices and with evidence-based research and a system of promising practices. Could you help me understand a little bit the differences between the two and why you favor one over the other?
Well, in the scientific community, there's always a prioritization around evidence-based practices, meaning, so for example, the reason why we put funding into evaluating our trainings was because we wanted to have the evidence that the training was impactful in the and met the goals that we set out for it, as opposed to best practices or promising or emerging practices are those practices that seem to have impact, but there have not yet been rigorous evaluation just because the research funding wasn't there.
Well, what population of providers are professionals that you're likely to train in the program?
So it's healthcare providers across the spectrum, from doctors, nurses, dentists, mental health providers, clinical social workers, school-based nurses as well, because they truly are at the front lines of early identification and also prevention of human trafficking so that the problem doesn't happen in the first place.
Might I just gently suggest that perhaps you could talk to professionals who are in the Office of Refugee Relocation, who are also under the Administration of Children and Families, because it does seem to be it seems to be missing from some of the hearings and briefings we've had on the issue of the unaccompanied minors in the lower Rio Grande Valley in my state of Texas. In fact, your physician, and unfortunately a physician is only hired by ORR in May of this year, even with the understanding that the problem was tumultuous and growing for several months before that. And your doctor reported to us that they only investigated cases of sexual assault if the victim so self-identified. Of course, these are children that we are talking about who are coming into these centers. In the state of Texas, it is a reportable crime. I'm a physician. I was required by law to report to state authorities if I thought a child had been abused, let alone was a victim of sexual assault. But I was required by law, and if I didn't report it, I was in trouble. And yet you have these children streaming across the Rio Grande River as unaccompanied minors, giving themselves up when they get across into Texas, taken into centers, evaluated by, sometimes DMAT teams, and although they do great work, the level of training you got to wonder about. ORR had just hired a doctor right before the summer started, and yet they were only investigating cases where a child said, I was a victim. And I mean, I was down in those intake centers. I mean, you'd have groups of kids sitting on a cement bench, a little group of 5-year-old boys. I got a 5-year-old grandson. I know how hard it is to get a 5-year-old to sit still. 5-year-old boys just sitting on this bench, stone still, staring into space. That's not normal. That's not normal behavior for a 5-year-old. A cell that was holding what looked like a class of third-grade girls, except, you realize they were all brought there by, or had turned themselves in. And these people had gotten across the entire state of, the entire country of Mexico through the deserts and the jungles and the difficulties by coyotes, who are human traffickers. Why aren't they further investigated? And when those cases are found, why are they not reported to state authorities so someone can go after the people who are the perpetrators and stop this problem, at least, if not once and for all, at least have a better handle on starting it? We're enablers right now, as far as I can see. We are codependents with the child traffickers, and it is not a pretty story. It does not reflect well on your agency. It does not reflect well on the Office of Refugee and Resettlement, and it needs to stop. Thank you, Mr. Chairman. I'll yield back my time. And if you wish.
Yes, please.
I think we have the same goals in mind in terms of the protection for these unaccompanied minors. And I thank you for your passion and your concern for this population. The Office of Refugee Resettlement, they are part of a working group, departmental working group on human trafficking, and I will learn more about what their practices are on the health piece in their screening for trafficking.
Let me just provide you some information. Every young woman or child, girl who's brought into the center over the age of 10 is given a pregnancy test. I presume there's a reason for that because they think something might have happened during this long journey up there, but then they're not further queried about the possibility of sexual assault. It was sort of like we're indifferent to the fact that these children may have been assaulted on the way up here. We're never going to be able to stop the bad guys if we don't do the fundamental police work. And your agency is sort of you're the tip of the spear there. That's where it should be happening, and unfortunately it's not. Again, thank you, Mr. Chairman, for the indulgence.
Chair, thanks for the question. Thanks to the gentleman, and thanks to witness for answering all your questions. We know that you have to leave to catch a plane. We will send follow-up questions, and I know other members will have questions in writing to you. We'll ask that you please respond promptly.
Thank you very much.
Thank you very much, Ms. John, for your time. And so we'll dismiss our first panel and introduce the second panel at this time. On our second panel, we have, and if the staff can set that up, and I'll introduce them in the order of their presentation. First, Ms. Vanita Carter, founder and executive director of Breaking Free. Then we have Ms. Laura Lederer, director of the Bastain Center for the Study of Human Trafficking, Indiana Wesleyan University. Then we have Dr. Hani Stokolosa, emergency physician, Brigham and Women's Hospital. And finally, Dr. Ken Miller, President, American Association of Nurse Practitioners. So if you'll take your seats, thank you all for coming. Your written testimony will be made a part of the record. You will each be given 5 minutes to summarize your testimony. And Ms. Carter, we'll start with you. You're recognized for 5 minutes. Welcome.
Chairman Pitts, Representative Elmers, and distinguished members of the committee.
Is the button pressed on your, yeah, if you can press that, pull it up close so the green light's on. Thank you.
Chairman Pitts, Representative Elmers, and distinguished members of the committee, thank you for inviting me to testify today to support this groundbreaking bill for the training of healthcare professionals to better work with victims of human trafficking. My name is Vanita Carter. I am a survivor of sexual exploitation. I am also the founder and executive director of Breaking Free, a nonprofit agency in St. Paul, Minnesota. Breaking Free's mission is to educate and provide services to women and girls who have been victims of abuse and sexual exploitation and need assistance escaping violence in their lives. Breaking Free is a survivor-led organization and provides services to more than 500 victims each year. In the case of virtually every sex trafficking victim we have worked with, they were recruited, coerced, defrauded, or forced into prostitution. Once girls and women are involved in the life of sex trafficking, it is extraordinarily difficult for them to escape. We can never forget that sex trafficking is modern-day slavery. Sex trafficking causes tremendous trauma for victims, from the physical abuse, emotional abuse, sexual abuse, kidnapping, and torture they have experienced. It is a terrifying and dangerous life. 83% of our clients at Breaking Free were assaulted with a deadly weapon. 57% were kidnapped before they escaped sex trafficking. 86% suffer from some type of emotional, physical, or mental disability. 71% of the victims we serve suffer from post-traumatic stress disorder. One survivor's story illustrates some of the health issues victims of sex trafficking face. As she told me, I was trafficked when I was 11 years old by my foster mother, who let her boyfriend sell us to other men. By the time I was 12, I had a pimp. During this time, I was beaten, burned, raped, and assaulted. Sometimes I went to a local neighborhood health clinic to be treated, but no one ever asked me what had happened to me. And if they did, I lied because I was afraid of my pimp. I had severe depression, anxiety, paranoia, and mental health issues, even after I became free. I got pregnant 6 times and had 6 abortions during this time. I had severe scar tissue from these abortions because there was no follow-up care. In a couple of cases, I had bad infections, so bad that I eventually had to have a hysterectomy. To this day, I have physical, mental, and emotional issues as a result of that time on the street. Another survivor told me, I was beaten, strangled, kicked, punched, raped, and hit on the head by my pimp. I wasn't able to escape until I was diagnosed with cervical cancer. And since then, have I been battling serious physical and mental health problems, including headaches, shortness of breath, bronchitis, chest pain, chlamydia, vaginal infections, and urinary tract infections. I also suffered from depression, anxiety, and panic attacks. I attempted suicide several times. All too often, victims of sex trafficking slip through the cracks of our medical system. Without appropriate training, health professionals are not able to put the pieces of the puzzle together to see that the woman or girl in their examination room is a sex trafficking victim. Or if the professional is able to see the signs, she or he doesn't know how to talk to a victim without shaming or re-traumatizing her. Or the professional may be unaware of community resources to help the victim. Healthcare professionals are in an excellent position to identify and help victims, but they need coordinated, evidence-based, and trauma-informed training to be able to do so. The Trafficking Awareness Training for Healthcare Act of 2014 offers the medical community the opportunity to develop best practices for identifying and caring for victims, and the opportunity to help thousands of victims in our nation break free. Thank you.
Chair thanks the gentlelady. Now recognize Ms. Letter, 5 minutes for opening statement.
Thank you, Mr. Chairman, and members of the committee. Thank you for the invitation today to testify and for calling this hearing to address the health effects of human trafficking and the need for training for healthcare provider sector. Over the last decade, we've looked at human trafficking as a human rights abuse and as a criminal justice problem. But in the past 5 years, it's become clear that human trafficking also has serious public and private health consequences, and that we need public policy and programmatic responses to train healthcare providers to identify victims and to respond appropriately. Today, I want to share with you the preliminary findings from a series of focus groups we conducted with domestic survivors of sex trafficking around the country. These focus groups provide evidence that women and children who are trafficked into prostitution are physically, mentally, emotionally devastated by the crime, and this devastation is lasting, with illnesses, injuries, and impairments starting during trafficking, but lasting often years longer. The full set of findings in charts and tables is available in my written testimony. I'm only going to outline the basic findings in my testimony here today. Survivors suffer tremendously, virtually without exception. In our study, 99.1% reported that they had at least one physical health problem during trafficking, and the majority reported dozens of health issues ranging from neurological, cardiovascular, respiratory, gastrointestinal, gynecological, dental, and dermatological problems. Survivors were also overwhelmingly traumatized, not only physically but mentally. The brutal treatment they endured created ongoing psychological and mental conditions in many victims, and also exploited existing mental instability in others. 98.1% reported at least one psychological issue during their captivity, with an average of more than a dozen psychological health problems indicated, including depression, flashbacks, panic attacks, helplessness, hyperalertness, disassociation, depersonalization, suicidal ideation, attempted suicide, post-traumatic stress disorder. Not surprisingly, survivors also reported significant numbers of reproductive health problems. More than 2/3 of the survivors we talked to contracted some form of sexually transmitted disease or infection, some STD or STI, including gonorrhea, syphilis, herpes, or chlamydia. Survivors also reported many issues around pregnancy. 71.2% of the survivors we talked to reported at least one pregnancy while being trafficked. 21.2% reported 5 or more pregnancies. 57.7% said they had at least one miscarriage. 29% said they had more than one miscarriage while being trafficked. 55.2% reported at least one abortion, with 30% reporting multiple abortions during the time that they were trafficked. The prevalence of forced abortion is an especially disturbing trend in sex trafficking. Prior research has noted the occurrence of forced abortion in victims of sex trafficking outside the United States, but our survivors indicated that they often did not elect to have abortions. More than half of those who answered the question indicated that their abortions were forced upon them. In addition, many more said they felt forced to choose abortion by the circumstance of being trafficked. How can I take care of my baby when he, her pimp, forced me out on the street every night to make money, one victim noted. Another said, in most of my 6 abortions, I was under serious pressure from my pimp to abort the babies. Notably, the phenomenon of forced abortion in sex trafficking transcends the political boundaries of the abortion debate. It violates both the pro-life belief that abortion takes an innocent life and the pro-choice ideal of a woman's freedom to make her own reproductive choices. Survivors were also the victims of violence and abuse at the hands of their traffickers. 95.1% in our study experienced some kind of violence or abuse, as Vanita said, including being shot, strangled, burned, kicked, punched, beaten, stabbed, raped, penetrated with a foreign object. Survivors also reported threats, intimidation, verbal abuse, and humiliation. Violence was the rule rather than the exception in trafficking. As one survivor said, "My pimp had his girls out on the street every night. It was either you made the quota of money for him or you got beaten." Many survivors reported being dependent upon drugs and alcohol while they were being trafficked, either because the substances were forced on them as a control mechanism by their traffickers, or because the substance abuse was a means of coping with their dire circumstances. 84.3% reported use or abuse of drugs, alcohol, or both during the time they were trafficked. And the most common substances mentioned were alcohol, marijuana, cocaine, crack cocaine, ecstasy, and heroin. Perhaps the most shocking finding of our study was that 87.8% of our survivors had sought medical care during the time that they were trafficked. The most frequently reported treatment site was the hospital emergency room, with 63.3% saying that they sought health care there. Survivors also had significant contact with healthcare clinics, that's 57.1%, including Planned Parenthoods, urgent care clinics, women's clinics, and neighborhood clinics in that order. So clearly, health providers are first responders, and they have a unique opportunity to communicate with and to intervene on behalf of victims. And for this reason, healthcare providers must be aware of the signs of trafficking in order to identify victims. An important part of this training will be to help health providers understand the coercive dynamic of trafficking, especially the extreme degree of control exercised by the trafficker and the prevalence of criminal exploitation of women and children. So we need specialized trainings tailored for the healthcare sector. These are a critical part of the solution. Setting up internal protocols and procedures and regulations may also further assist the healthcare providers in identifying, treating, and responding to, and reporting, as well as referring, where necessary, trafficking victims. Finally, we absolutely need more research to help us understand the healthcare problems and the needs of trafficking victims, as well as to identify best practices and to create national, state, and local responses to health consequences of trafficking. The medical community can play a vital role in the ongoing fight to eliminate modern-day slavery, and HR, whatever the number is going to be, the Trafficking Awareness Training for Healthcare Act of 2014 is an important step in helping to equip them for this fight, and I thank you so much for having us here today to begin this conversation.
Chair, thanks, gentlelady. Now recognizes Dr. Stoklosa, 5 minutes for opening statement.
Chairman Pitts and Ranking Member Pallone, thank you for inviting me to testify today, and Representative Elmers, thank you so much for putting forth this bill. And I'd also like to express my appreciation to Vanita Carter for her courage in sharing the survivor perspective. I'm an emergency medicine physician at Brigham Women's Hospital in Boston, as well as faculty at Harvard Medical School. In Boston, I convene a citywide task force looking at developing a health protocol for victims of trafficking when they come to our healthcare settings. In addition, I do international research on human trafficking, including a monitoring and evaluation study of anti-trafficking programs in India, as well as looking at the health consequences of human trafficking among construction workers in Kazakhstan. I co-founded HEAL Trafficking in the fall of 2013. HEAL stands for Health, Professional, Education, Advocacy, and Linkages. And our vision really is to unite health professionals who are working on the issue of human trafficking. We're divided into working groups that work at are working on the issues that are at the crux of health and trafficking, including education and training, protocols, research, direct service, prevention, and advocacy. HEAL Trafficking brings together a broad range of health providers, including administrators, researchers, dentists, social workers, nurse practitioners, and physicians. And we are pleased to work very closely, especially our education and training group, with the SOAR initiative within the Department of Health and Human Services. I'm going to share with you a story from the emergency room. This was early on in my training, and it was a busy overnight shift, seeing lots and lots of patients. And I took care of this young woman who was Cantonese speaking who came into the emergency room, and her chief complaint, the main reason that she was there was she had abdominal pain. And from a medical perspective, it was a really straightforward case. We diagnosed her with a sexually transmitted infection, we treated her appropriately, and then we discharged her home. I knew that something wasn't right. I couldn't put my finger on it, and there was this dynamic in the room with an older, also Cantonese-speaking woman, but I didn't have any training on human trafficking, and so I missed this case of human trafficking. Later on, as I learned what trafficking was and that it was actually happening in the United States, I realized that I missed this opportunity with this young woman, this opportunity to intervene at her time of need and her interface with the healthcare setting. Unfortunately, this happens all too often. Victims of trafficking are coming to our hospitals and clinics, and they're leaving unrecognized and uncared for. There are three crucial considerations when we look at developing a healthcare initiative for education of our health providers nationally. These considerations are who, what, and then what. So the who, and Catherine Chun alluded to this, but we really need to train all healthcare providers across disciplines as well as across specialties. In terms of the disciplines, we need to train social workers, EMTs that are responding in ambulances, physicians, nurse practitioners, and we need to train across specialties. We need to train obstetrics and gynecology specialists, dermatologists, emergency room providers, surgeons, family medicine providers. We need to train the full spectrum. And in addition, we need to train them across the spectrum of their education. So from the physician perspective, from medical school all the way on up to my board certification process, this needs to be integrated at every stage. The second is the what. The content of the training, the Department of Health and Human Services is working on developing the evidence-based content, and I think crucial in that is having trauma-informed, survivor-led expertise. When I talk to survivors, their everyday lived experience is often a very deep-seated, complex experience of PTSD due to the repeated physical and emotional and sexual abuse that they experienced during the time that they were exploited. And our health settings and our health providers need to be sensitive to that. They need to provide a welcoming environment where they aren't even inadvertently re-victimizing victims of trafficking. And if they don't trust a health provider, if they don't trust that health setting, there's no way that that health provider is going to get the information they need to be able to identify them as a victim. The last piece here is that we need to develop a strong referral infrastructure. The current state of resources for survivors is inadequate and disorganized. And just imagine as we identify further victims of trafficking, what that's going to do to burden our already burdened system. Survivor care is a long-term process, and survivors need to know that they're better off in our healthcare system than they are in the arms of their exploiter. So in summary, who should we train? We should train all healthcare providers in terms of what it needs to be trauma-informed and survivor-led, and we need to expand resources for referral. Thank you so much.
Chair, thanks, gentlelady, and now recognize Dr. Miller, 5 minutes for an opening statement.
Thank you, Chairman Pitts, Ranking Member Pallone, and members of the subcommittee. I appreciate the opportunity to speak with you today on behalf of the American Association of Nurse Practitioners, the largest full-service professional membership organization for NPs of all specialties. With nearly 52,000 individual members and over 200 organization members, we represent the more than 192,000 nurse practitioners across the nation. My name is Ken Miller, and I am currently serving as the president of the American Association of Nurse Practitioners. I have also served in many different academic administrative roles across the country. I've also worked as a family nurse practitioner in New Mexico, Delaware, and the District of Columbia. NPs have been providing primary, acute, and specialty care for half a century. We are rapidly becoming the healthcare provider of choice for millions of Americans. In fact, we conducted over 900 million patient visits throughout the United States in 2013. NPs practice in every community in this country, both urban and rural, and see patients from all economic and social backgrounds. We provide care in all types of settings, which include clinics, hospitals, emergency rooms, urgent care sites, private physician or NP practices, nursing homes, schools, colleges, retail clinics, public health departments, and homeless clinics. It is also important to remember that in many of these settings, NPs are the lead provider on site. In fact, there are many NP-owned and managed clinics across the United States. It is in these various settings, particularly public health departments and primary care clinics, where NPs play a key role in recognizing many of the at-risk vulnerable populations they treat. NPs, with their emphasis on primary care, health promotion, and education, coupled with their nursing background, approach the care of their patients holistically. Their expert assessment and interviewing skills, combined with their education and preparation, uniquely positions them to gather information which not only allows them to treat symptoms, but also research causality, crucial to effective prevention of emotional, physical, or sexual abuse. Knowing the correct assessments to perform and the right questions to ask when treating patients that are victims of other types of violent crime and abuse is a skill set similar to what NPs must call upon when recognizing and treating victims of human trafficking. We know today that practicing NPs are confronted with patients whom they suspect are victims of human trafficking, and that we must lead and work with other provider groups to develop best practices and procedures that will allow all providers to attain the skills needed to ensure that these victims are identified, treated, and assisted. It is imperative that providers are given clear instruction and guidance on how to identify these victims, as well as the steps to be taken to ensure that victims receive the proper protection and care. These best practices need to be carefully developed given the variety of providers and the different care settings in which these victims may surface. Victims of human trafficking can be extremely difficult to locate after their initial health care visit due to the transient nature of these criminal acts. It is critical that best practices include a program that provides guidance and gives providers the tools necessary to assist victims as quickly as possible. We must ensure that providers and victims working together can develop these evidence-based best practices and work to implement them across the healthcare spectrum. In closing, it is important to note that strategies may vary from clinic to clinic and from state to state. Developing best practices to identify signs and symptoms and best screening tools is paramount to identifying those who are trafficked. Reporting procedures are key to removing the victim from their deplorable situation. For any program to be effective, all healthcare professionals that come into contact with suspected victims of abuse must be educated and clinically trained to identify these individuals. We are pleased to continue to work with Congresswoman Elmers and other members of the subcommittee to develop legislation that addresses this issue in a provider-neutral manner. This ensures that all practicing providers and healthcare personnel who may come in contact with victims of human trafficking are able to identify and assist them. As the voice of nurse practitioner, AAMP can reach the rapidly growing NP profession throughout the country with this important information. We thank you for your time and respectfully request that we continue to work together on this important issue.
Chair thanks the gentleman. Thanks all the witnesses for your very important testimony, very moving testimony. I'll begin questioning and recognize myself 5 minutes for that purpose. Ms. Carter, let me start with you. While anyone can become a victim of trafficking, are there certain populations that are especially vulnerable to trafficking? Make sure you pull that close. Thank you.
The Native American community and African American women are very highly, they're preyed upon. They're preyed upon. And those are the communities that Breaking Free is in Minnesota. And so Minnesota is less than 10% of the population are African American, less than 2% are Native American. Yet and still the majority of the 500 women and girls we work with a year are African American and Native American. So those are the populations that are very highly susceptible to being trafficked.
Thank you. Ms. Letter, because human trafficking is considered to be one of the fastest growing criminal industries, the U.S. government and academic researchers are currently working on an up-to-date estimate of the total number of trafficked persons in the United States annually. Do you know how they collect this information?
In the United States?
Yes.
Chairman Pitts, I don't believe that there is a solid number yet. I would like to add to what Vanita said. I absolutely agree that those populations are vulnerable, but there are also many other populations that are vulnerable to being trafficked. We know that runaways and these homeless and what we call the throwaway kids, the kids who don't really have places, homes where they have a loving environment, are very vulnerable to trafficking. And in all of the survivors that I've interviewed, there was something that happened in the home early on, some abuse, either physical, sexual, that drove these children out onto the streets. And then out on the streets, they're much more vulnerable. We have some estimates of those vulnerable populations. We have heard that it's somewhere between 1 million and 1.5 million that are these runaway, homeless, and throwaway youth, and they are all susceptible to trafficking and are preyed upon by traffickers who know exactly what to look for and where to find them. So I think that part of what we've done is we've begun to identify large vulnerable populations, and what we need to do next is take a much more critical laser-like look at what is happening in those populations. For instance, we know that street gangs are now preying on children in middle schools, and that they are literally going to middle schools and high schools and recruiting from there. But we don't know the who, what, when, where, how of that. And we will need specific studies to be able to identify that. And I am with you. I think we need to be able to figure out on the front end who are these vulnerable populations and prevent the trafficking so that we're not constantly doing the cleanup that we've been doing over the past 10, 15 years.
Thank you, Dr. Stucklosa. You mentioned your specific patient. You said you missed the stage of trafficking. I think it's what you said, and that you must establish trust. What are the indicators that you look for to identify trafficking victim in your experience as a physician in Boston?
Thank you for the question. I would couch this by saying we need more evidence and we need more research to show us what those signs and symptoms are. But in talking to survivors and from the studies that we have thus far, some of the signs of symptoms, and I kind of go to head to toe whenever I train healthcare providers on this. General malnutrition, a discrepancy between their story and what you're seeing. So they say, just very similar to intimate partner violence, they're saying, oh, I fell down the stairs, when there are bruises that are at multiple stages of healing on their body, cuts or lacerations without an explanation, tattoos where they're afraid to talk about them. Maybe it's a pimp, or maybe it's his branding on them. I've spoken with survivors that have been literally hogtied and branded. So that's on the skin side of things. They may have eye damage from either being beaten or being kept in dark places, and so their vision may be impaired from that. Signs of oral trauma, including sexually transmitted infections that may even present in the mouth, pulmonary disease, lung trauma, and then and the reproductive side of things, scar tissue that's unexplained, presentations of sexually transmitted infections that have gone farther than one would expect before they sought medical care, and retained foreign bodies either in the vagina or in the rectum, from being forced from a female perspective, being forced to have sex during her menses. I could go on from there, but those are some of the signs and symptoms that would be concerning.
Thank you. Dr. Miller, health clinics, hospitals, social welfare offices, police frequently and unknowingly experience face-to-face contact with traffic victims. How do you think this bill will help improve identification of trafficking victims among healthcare providers?
I think one of the most important things that it will do is it will establish a program to educate all healthcare providers. I think many of us get pieces of that throughout our programs when we are working for our degrees, but I don't think there's any real focus that is totally limited to trafficking. I think we talk a lot about abuse, and we get a lot of information about that, but there's nothing specific to trafficking. And I think having this program will really aid us in being much more astute in identifying patients who are human trafficking.
Chair, thanks the gentlemen, all the witnesses for your answers. I've gone over my time. I yield 5 minutes to the ranking member, Mr. Plone, for questions.
Thank you, Mr. Chairman. Earlier this morning, we heard from Ms. Chon about the SOAR Health and Wellness Training Initiative at HIS, a pilot program to improve healthcare professionals' response to human trafficking. I wanted to ask Dr. Stoklosa, since you participated in the technical working group for SOAR, I'd like to get your thoughts on this new initiative. The pilot training for SOAR began this week and it's happening in 5 states over the next month. So will you be involved in the training in Boston next week, and what did you see for the type of training that SOAR offers in your community?
Thank you so much for the question. So both on the HEAL national level as well as individually, I've been really pleased to be involved in the SOAR initiative to health and wellness. And part of it's based on a very well thought out process in the development of the curriculum, and really addressing this unmet need in terms of educating our health providers. The HEAL trafficking group, especially the education and training group, has been interfacing both in terms of input on the technical advisory group, both in terms of myself as well as others. We're really pleased with the ultimate outcome of the pilot training, but it is a pilot training, and we're pleased that this is going to do is add to the evidence base on educating and training our health providers.
Have you seen much interest in the SOAR program in Boston, and what types of healthcare providers have already signed up for the SOAR pilot training?
So I will be, along with a couple other colleagues, will be doing the training in Boston, and there's been an overwhelming response within the Boston healthcare community, both within my own hospital system as well as across the city of Boston. And those that have signed up have come from the spectrum of healthcare disciplines as well as specialties, including social workers, dentists, from obstetrics and gynecology to trauma surgeons. So we're very thrilled to see that response, and I think it's reflective of the hunger for this education and training, and the realization that we are interfacing with victims of trafficking, but we don't have the tools as health providers to identify them or care for them.
Well, thanks. After the pilot sessions this month, participants in SWORD training will complete evaluations of their experience, which will help HHS to assess the effectiveness of the program and determine how to move forward. What are your hopes for the future of the SWORD training program?
So, you know, this is the pilot round, as you said, and my hope is that this will provide an evidence base so that we can have fidelity for the education and training of health professionals nationally. As Catherine Chun mentioned, this is kind of the 101. This is the general awareness piece. Certainly, every health provider in the United States, once we've shown that this is an effective model, should be trained, and that should be incorporated at all stages, as I mentioned earlier, of our education and training, from the very early ages or early stages within professional school, all the way along through our accreditation processes, as in whatever board certification or professional accreditation processes are specific to those individual disciplines. And I see HHS really taking a lead in facilitating this effort.
Well, thanks, and I want to say I look forward to learning more about the results of this pilot program so we can determine how the federal government can best help healthcare professionals, along with any other individuals like to interact with the trafficking victims. I did want to issue one more thing, though. This would be either to you or Dr. Lederer. Current statistics on human trafficking in the U.S. are limited, and as Ms. Chon noted in her testimony, while researchers like Dr. Lederer have begun to look at the health effects of trafficking, more research is clearly needed to better understand the health needs of victims of human trafficking, as well as how healthcare professionals can best address the needs. Could either of you ask what need do you see for further research regarding the interaction of victims of human trafficking with the healthcare system, either Ms. Lederer or Dr. Stucklosa, or both of you?
Thank you for the question, which is an excellent question. I think we're in the foothills of consciousness in terms of figuring out what kind of research needs to be done. I believe that we need to, like Dr. Stucklosa's head to toe, we kind of need to go very beginning and track. So I've talked to 150 survivors across the United States over the last year, and I've heard recurring themes, and I would start with those recurring themes. One of them is abuse in the home. Once somebody's been abused, whether they've been sexually assaulted, they've been raped, they've been molested by a relative, they are pushed out into the streets. And so we need to do a lot more research on the link between early abuse in the home and trafficking. Then foster care systems. Once they're out of their homes, they're into our foster care system, and we need more research on how foster care system is working. I believe that those systems are failing and are facilitating trafficking at this point in time. So we need more research in that area. Educational systems. We need more research on the link between bullying and trafficking, on the link between the ways that street gangs and others prey on. What is the role of the educational system right now? How do they facilitate, or how are they failing to counter trafficking? And I can go through each of the various sectors. I think that's important. I agree with Dr. Stucklosa that all of this needs to begin from the listening to survivors. If we listen to survivors, they can tell us how to proceed. They know the hell of this. They know what works and what doesn't work. They can tell us better than any textbook what we need to do. And so we need to incorporate survivors into all our programs. And then the last thing I would say is that the huge, huge need, which is the elephant in the room, is the resources and referral. Once we've got these trainings in place, and Representative Elmers, thank you so much for taking the lead on this. This has been such a long time coming. But once we do have these trainings and we begin to identify these victims, we will need thousands of breaking frees. and we will need to have them up and running so that they can do their work properly. So there's a lot of research. I would be happy to do a fledgling list for you, just beginning and think about this further with my colleagues, but that's a start.
Thank you.
And if I may, I'd like to add on to that and concur with Laura Letter's comments. One of the gaps that I see is the populations that we have data on thus far in terms of intersection with healthcare. So there is more information, though it's still not as much as I would like, on sort of the pediatric or the child populations specific to sex trafficking. We don't know a lot about labor trafficking. We don't know a lot about, as much as I would like, about the adult populations and transgender populations and boys. There are a lot of men and boys that are involved in trafficking, and there are largely in a hidden population, hidden within that. And they're especially vulnerable, and we don't have much data on them. The other thing that I would like to add here in terms of the need to add to the evidence base is in terms of going back to trauma-informed care. Trauma-informed care is something that healthcare providers really have no training on at all. And I mentioned earlier, victims of trafficking especially are in this reality that we're not trained to deal with. And as a result, we accidentally, in most cases, re-victimize them when they enter our health facilities, and therefore they're not going to disclose what's really going on. We need more data around trauma-informed care to show what works and what doesn't work. And we need to train our healthcare workforce in it. And it's not only applicable to victims of trafficking, but we as healthcare providers interact with patients that have experienced violence along the entire span of their life, unfortunately, from child abuse to elder abuse to intimate partner violence, and yet we still have the no training in trauma-informed care. So I think in some ways this gives us an opportunity to expand that very much needed toolkit for healthcare providers. And I would echo Laura's comments in terms of needing more resources dedicated both to the research as well as to the aftercare for victims of trauma. Doctors, and I'm speaking from that perspective just personally, you don't want to ask the questions if you don't have a plan, if you don't have a solution to be able to provide. And so if you know that the shelters are limited for somebody that's being trafficked, it's in some ways it's like an unconscious decision, but you'd rather not even ask and explore that. And so we're also missing opportunities because of that.
Thank you.
Thank you. The gentleman yields back. I am now going to finish up. If any of our other colleagues come in, we will certainly allow them time for questions. I want to start off, and at first, I just want to say thank you to our panel. Thank every one of you. Ms. Carter, especially for your bravery, for taking your experience and turning it into something positive. It's hard for me to talk about without getting emotional, so I apologize. We should have done this a long time ago. The fact that we are here today on September 11th,
Yes.
and in recognition of a very emotional day for us as Americans, and talking about this issue, I think is significant. And again, I thank all of you, because it's all of us working together on this issue where we are going to solve this problem in this country. My goal is to eradicate human trafficking. And Dr. Stuckalosa, you touched on the labor trafficking that occurs. We are also looking at that as well, because that is another area that, although we as Americans know that it exists, we really don't want to accept that it exists, and we need to be able to identify that. And Ms. Carter, I do have well, first I want to make a comment just about the prevalence here in this country, and reference an NIH study in regard to trafficking. NIH estimates that 50,000 people are trafficked each year in the United States, with as many as 400,000 of our minor children involved in trafficking, resulting in, and this is the question. The question is why is this happening? What is the precipitating factor that creates trafficking? And the answer is the dollars.
Yes.
The dollars.
Yep.
It is a very profitable criminal industry, resulting in billions of dollars being generated from it. And I do, Ms. Carter, I want to just go back to your testimony and your experience and now what you are learning when you are working with victims. One of the things that hit me as, you know, working as a nurse for so many years, Dr. Stucklasa, I know exactly what you say when you know something's wrong, but you just can't put your finger on it. And then what would you do if you were to get that knowledge, that information from that patient? One of the things that I was struck by was the fact that many of the pimps or the human traffickers, that it's the attraction, the security, and the love that the victim feels that they're receiving from that individual because of their life experience. This may be the most secure thing that they have ever encountered, and that's why sometimes it is so difficult to identify them. Ms. Carter, can you speak a little bit about that? Is that something that you have also seen?
Yes, definitely. I want to say it is a brainwashing process because we know that the average age of entry in our country is between 12 and 14 years old. So when you have a 12-year-old that's ran away from home, that's out there on the street, it doesn't take a trafficker a lot of effort to convince her that he's going to help her and he understands what she's been through. So there's it's kind of like a two-phase process. First, he gets her to believe that he's going to do all these things for her, and second, he tells her now that she owes him for doing all these things for her. So at 12 years old, you're full of fear because you've been told that if you don't do this, I'm going to go and I'm going to do this to your sister, I'm going to kill your brother, I'm going to, you know, just all kinds of threats. So it doesn't take a lot of convincing to get a child involved in this life. And there are different types of pimps. You have just your hardcore pimp. He knows you're on the run. He knows you're out there. You have no place to go. He immediately just turns you out. And then you have the other kind that just convinces you that he's everything to you. And she believes him. Why wouldn't she? She can't go get a job. She can't rent an apartment. She can't do anything. And she can't go back home because that's where all the abuse started. So it is a process.
Thank you, Ms. Carter. Dr. Lederer, one of the things in going over and with the focus group information that you have provided to us, that was the eye-opening experience that I had. Again, understanding and knowing the healthcare community and how much any healthcare provider would want to be able to identify these victims. And then to find out that from your focus groups that 87% go to our healthcare providers, to our clinics, to our emergency rooms, and receive care. It was difficult for me to accept that because I just assumed that these things were happening behind the scenes. They were not out in the open, and that we as healthcare providers would not be able to identify those victims. But when you think about it, it makes perfect sense. Because there again, they are the product, and that product has to continue to be sold. Yeah. So therefore, they do seek health care. Their traffickers do seek health care. And one of the points, and there again, I realize we are just at the tip of the iceberg here. This is going to be an ongoing discussion into the future so that we can again eradicate this terrible, terrible crime. But one of the things, and I'm going to have Dr. Miller, I'd like for you to comment on this as well. As far as you know, expanding, we've all discussed areas where we need to go with this. I do want to go back to our schools with our school nurses and our social workers. Dr. Lederer, do you believe that this is an area that we also need to incorporate into these programs? And then Dr. Miller, I'd like for you to.
Absolutely, I do. And I am not a healthcare provider, so I don't know all of the various subsectors of that sector. But I think the disappointment over the last 15 years is that all these trainings have been like a one-off. If there has been a training, it's been a hospital. It's been two things. It's been a hospital calling and saying, we'd like a training to do as part of this seminar that we're putting on. Will you come? And then the anti-trafficking organization comes, gives a tip 101 and goes home. So it's not only one-off, it's reactive instead of proactive. And what we need is both proactive and we need a methodical approach. And again, I like Dr. Stoklosa's approach of from the beginning in the academies all the way through all of these, the sector and the subsectors. We absolutely need training, and I believe we need training tailored to each of those subsectors. So school nurses will need a specialized training because they're dealing with a specialized community, and they will need to know not only what to look for, but how to respond, you know, properly without driving the kids back out onto the, onto the streets as I think if you're not equipped, you can do if you're a counselor or a nurse and don't know what to do, what to say, and who to refer to. So that's a perfect place to begin. And it's at that early stage where if we can prevent it from happening, we're way ahead of the ballgame. Because once somebody's been trafficked, they are, as we've all been saying, physically, mentally, emotionally, spiritually devastated. And building that person back up again is almost impossible. We spend a lot of time and money. No one's done the cost-benefit analysis. That's the other big study that needs to be done. How much is this costing us to do these rescues, restorations, reintegrations? It's huge. So that's a good place to start.
Dr. Miller.
Yes, I believe that the academic institutions, whether it's grade school, high school, or collegiate level, need to be much more proactive. And the only way they're going to be proactive is if they get the education that they need. And again, I can tell you that in many of the programs around the country, what you hear on abuse is you may have 1 or 2 classes, and that's it. And what they really need is to have a workshop, and that workshop needs to be incorporated throughout the entire curriculum for the entire length of time that the person is in the program. But I also concur that one of the things that needs to be done is it has to be focused on whatever level. If it's a school nurse, if it's a nurse practitioner, if it's a physician, if it's a social worker, whatever their program of study is, it really has to be focused in that area. So that means we're going to have to be developing programs that are really attentive to those types of disciplines.
Thank you. And my last question or discussion, really, because I'm going to direct this to Dr. Stoklosa, but I would like anyone else who would like to comment as well. There again, getting back to the objective that we have, obviously our goal is to incorporate programs, if you figure out ways, protocols for best practices on all of these issues. And there again, to the point of prevention, it's so important. You know, Ms. Leder was talking about the cost or cost-benefit analysis in the long run. You know, one of the other areas that we're working on here on the Health Subcommittee is need for mental health reform. And when I think of the number of victims who now fall into and need mental health care, and that opens up another door to more cost and continued life situations that they will be affected in their entire lives. What I'd like to know, Dr. Stoklosa, from your perspective right now, I was paying special attention to what you're identifying to the chairman about what you see or what some of the identifying signs and symptoms that you see today in the emergency room. One of them, of course, was you had mentioned tattooing and branding. And that a light bulb went off in my head, and I thought, my goodness. These women, I mean, when we're talking about modern day slavery, these women, these children, these men are being branded, and we attribute much of that to gang activity. And you know, there again, I can see how healthcare professionals would just make the assumption that this is a gang member or a prostitute on the street and chosen lifestyle. Versus someone who would fall into that human trafficking victim category. There again, my mind is going crazy with ideas of what we need to do into the future. What do you see now? If a patient comes into the emergency room and you identify them as a potential sex traffic victim, what do you do from that point on, and what barriers exist that we need to be identifying today so that we know where to go tomorrow?
Thank you for that question. And you brought up a lot of points along the way that I could spend forever kind of commenting on, but I'm gonna get to the what do you do in that moment, and this gets to that kind of then what question. I'm going to speak as a clinician in Massachusetts at the moment, but it depends on age, first of all. So if they're under the age of 18, there are mandated reporting requirements. I should say before I even get into the age thing, the most important consideration is to meet the victim or the survivor where they're at in that moment. So while for an under age 18 individual, I am ultimately going to need to initiate a mandating reporting pathway. If the patient in front of me feels like I'm all about rescuing them and doing X, Y, and Z, and I'm not there in the moment assessing their need for food, maybe for water, for just having that human interaction, all is lost, really. But so under the age of 18, mandated reporting, and that would initiate Child Protective Services. There's also in Massachusetts, we're lucky enough to have the SEEN Coalition, which is a wraparound set of services for those that are victims of sexual exploitation under the age of 18, which includes legal services, mental health services, and we try to limit the number of even health providers that are asking them about their traumatic experience to make sure that it's not re-traumatizing for them in that situation, and then referral to services. Obviously, we take care of their medical needs as well. If they're over the age of 18, it's finding out where they're at and what they want. Maybe it really is just a sandwich. Maybe they're not ready to get out of that situation. It's very akin in many ways to what we've seen with intimate partner violence. They ultimately have agency in that situation. As hard as it is to let them go back out, in some cases that is the choice that's made. I see it as a spectrum, that their interaction with caring individuals, whether it be interaction with the healthcare setting or other providers, ultimately they may get to that point where they're able to say that I want to be out of this situation. We have to recognize that sometimes it's actually less safe for them to disclose that information. They may know that if some information gets back to their pimp that they're going to be beaten that evening if they were to disclose. They may have extreme levels of blackmail that are kind of wielded over their heads, either against their family, told that their family is going to be murdered, or that pictures are going to be shown to those that love them and care for them. So we have no idea what is actually going on in their minds, and that's a really important thing for providers to realize, and it's really about meeting them where they're at. And then just in terms of the barriers of judgment on behalf of healthcare providers, as you're saying, they may just be like, oh, this is a prostitute, she's choosing it. A lot of these victims present with substance abuse issues. And what I tell health providers is that those are opportunities for us. There was a case in New England last year where a health provider asked someone who had come in with a heroin overdose, I've seen you've been here a number of times with this, like, how did you get hooked on heroin? And then she reported that it was her pimp, and from there they were able to uncover this entire trafficking ring. So it's being aware of the signs and symptoms, and being and really coming at it with that trauma-informed approach. And then further barriers are on the referral side. So like, what then? I have them call the National Human Trafficking Hotline. They're a great resource, both for the survivor to talk to, or if the survivor's not in that position yet, I can speak in a way that's HIPAA compliant with the National Human Trafficking Hotline, so that's also a great resource. But there have to be resources under that. There have to be roots to that system. If there's no infrastructure for me to refer to, maybe he or she is in some ways better off being in the hands of their exploiter. I mean, it really is a tough state of affairs.
Would anyone else like to comment on this situation of, again, even talking about barriers that exist right now, and what we're doing today that in the future we can improve upon? Okay, Dr. Stocklosa, you covered that very well. I think we're at a point where we can close our meeting. We will have 10 business days to submit questions for the record, and I ask the witnesses to respond to the questions promptly. I would imagine that many of the members who could not be here for the subcommittee because of ongoing things that are happening today, that you will probably receive some written questions, and then members should submit their questions by the close of business day on Thursday, September 25th. Before I adjourn, I just want to thank you again for coming, testifying on this incredibly emotional and vitally important issue. This is something that we can all work on. This is definitely a bipartisan issue that everyone has input on and will be able to come together. And I just feel so strongly that we need to be doing everything we can to make this happen. And I look forward to working with all of you. Please know that my door is open. The committee is, more than happy to take more of your input, and let's work together on the solutions that we need to find. With that, and without objection, the subcommittee is adjourned.